All right, I think it's about time we get started. How are you today, Robin?
Great, Scott. It's wonderful to be here.
Well, I'm so excited that you're here. It's always a pleasure to have you come and speak with us. Um, for anyone that is not familiar, Robin Martinez is the coordinator of online communities at smartpatients.com. And if you're unfamiliar with Smart Patients, I highly encourage you to check it out. It's a forum of sorts for people and patients of kidney of all types of ailments and caregivers to talk through issues and get feedback from people that are having similar experiences. And I know it's a fantastic resource to the community, and we're lucky to have you here today. And so Robin is here to speak about if you have kidney cancer, who should be on your team. So without any further ado, before we get started, there will be a Q&A session at the end. So if you do have any questions, you can type them into the chat box, and we'll make sure to have your questions answered. So without any further ado, take it away, Robin.
Hi, everyone. It's great to see you all here today. We're going to start with a simple case of kidney cancer. Somebody goes to their primary doctor. They're not feeling that great. They have vague symptoms. Somewhere along the line, they probably get a CT scan. And then it's found that they have a kidney tumor. At that point, care usually is switched to the urologic surgeon. The urologist will do the surgery to take out either the kidney, the whole kidney, or take out the tumor itself, which is a partial nephrectomy. Partial nephrectomy is better if you can get it, but it is a more complicated operation. Nowadays, also, people get laparoscopic kidney removal, and that can be a shorter recovery time. The disadvantage is that the surgeon doesn't get to look around inside as much, but the advantage is it is easier on the patient. So now you've had a successful surgery, and the surgeon says, great, we got it all. What does that mean? That means I got all I could see. All the visible cancer is gone. Does not mean that you are free and clear forever and ever. Unfortunately, kidney cancer can return even though the entire primary tumor and all the visible cancer was successfully removed. So that means that you have an ongoing need for surveillance. So the first doctors that you will probably see after your surgery and after the surgeon says, oh, you're good to go, everything's back to normal, you're going to see somebody for follow-up. And often that's the urologist. Sometimes that's your primary care doctor. And they're going to order scans for you on a regular basis. And we call this surveillance. There are many different kinds of scans, and usually the scan that is done to check for metastases both before the surgery to make sure that it's an early stage tumor and after the surgery to make sure no metastases have showed up. The gold standard is the CAT scan of the chest, abdomen, and pelvis with contrast. Contrast is important because when you're looking for things that you don't already know are there, contrast will help any abnormality show up. If you already know something is there, contrast isn't quite as important because you know where to look. But you get these scans on a regular basis. And then if necessary, if you start to develop symptoms of a neurological problem, any kind of neurological problem, or any kind of bone problem, a new bone ache, something like a muscle pull that doesn't go away after 6 weeks or so, you might get scans of your brain for any neurological problems or your bone for any type of bone pain. Or, as I said, a muscle pull that doesn't go away in a normally expected period of time, that can easily be a symptom of a bone metastasis. My general theory is if something goes on for 6 weeks, if you have a problem for 6 weeks, you probably should rule out that it's not the cancer recurring. And especially if you get treatment for something, your doctor says, oh, it's just so-and-so, and gives you normal treatment, gives you an antibiotic, gives you a pain pill, whatever, and the problem is still going on, and the doctor wants to repeat the standard treatment. At that point, you say, wait a minute, let's rule out the cancer first. But generally, that's all done with surveillance and scanning. Now, at some point, especially if you have metastases, you're going to bring in an oncologist. An oncologist deals in cancer. The urologist deals in all kinds of urologic problems. So when do you need an oncologist and why do you need an oncologist? Lots of people don't hear the word oncology until they have definite metastases. Metastases means spread to different organs. If you can, it's a good idea to touch base with oncology before that happens. Just say, what oncologist would I use? Where would I go? Who would it be? Do I need to see one right now? And if you develop metastasis, you want to make sure that you are in the hands of an expert who deals with enough renal cell carcinoma to be able to give you really well-informed care. One reason for this is renal cell carcinoma is a relatively rare cancer. It's like number 10 or 11 at this point in the list of frequency of adult cancers. And many doctors, many oncologists don't see renal cell carcinoma that often. So an expert will see maybe 50% of their patients will be kidney cancer patients. That's much better for the patient because these doctors deal with it all the time. They know exactly what's going on in the field. They know all the options. Currently, we have something like 16 or 17 approved drugs from the FDA, and they're used individually, they're used in combination, and the expert oncologist is your best bet to be able to guide you to which treatment you want when. In the US, people get sequential treatments for metastases if the metastases don't go away. Of course, the goal is to get rid of all the cancer, but a lot of times that doesn't happen. A lot of times what happens is you can stabilize the cancer, but you have to stay on treatment. If you need to be on treatment, you want to make sure, number one, that it's the most appropriate treatment for you. And that really, unfortunately, is not very well studied. We have ideas about what to do first and what to do second, but there's no definite hierarchy of treatments, like first you get this, second you get that, third you get this. If that doesn't work, then you go on. It's a matter of gut feeling, where your metastases are, what your doctor likes to use, whether you want to be at home or whether you want to come in for infusions, how young you are, all sorts of considerations. What type of renal cell carcinoma do you have? Do you have clear cell? Do you have one of the less common subtypes that are more resistant to treatment? Do you have a genetic type? And if you were diagnosed before the age of 46, you should have a genetic workup to make sure there isn't a genetic component in your cancer. If there is a genetic component, if you have something like von Hippel-Lindau syndrome, which is pretty rare, or Birt-Hogg-Dubé, or one of the others, HLRCC, hereditary leiomyomatosis, and renal cell cancer, or the other genetic syndromes that involve kidney cancer, then you might need a different surveillance schedule. You might need a different treatment approach. But the oncologist generally is involved with supervising your cancer care and giving you drugs to treat metastases. And then once the metastases are gone, which we all hope for, you'll still stay in touch with the oncologist to make sure that the cancer hasn't come back. Now, a lot of people say, what about a nephrologist, a kidney doctor? Don't I need a kidney doctor? I've got a problem with my kidneys. Well, actually, no, you don't. Most people with kidney cancer do not have a problem with kidney function. Their kidney or kidneys are still doing a great job of producing urine. Their creatinine is within normal limits or close to it. The kidney is healthy. And if the kidney is healthy, then you probably don't need to even take any precautions. But if you want to cut back on salt and not overdo certain things like protein, that's fine, that's great. But do you need a nephrologist? If you have a significant decrease in your kidney function, or if you have a family history of lupus or diabetes or have these diseases yourself, some conditions predispose patients to kidney problems. In that case, you probably should be in touch. You need to be in touch with a nephrologist to supervise and make sure that your kidney keeps functioning in a healthy way. Now, what about lab tests? A lot of cancers have a lot of lab testing. But for kidney cancer, generally, we just have lab tests for anemia, for liver enzymes, for blood calcium level, and those things can indicate whether you have a general type of problem, and they might indicate that, like with the liver enzymes, if you have elevated liver enzymes, there might be a problem with your liver, but it might not be cancer, it might be something else. But it could be cancer, it could be a metastasis. If you have an elevated blood cancer level, there are a number of things that can cause that, but one thing that can is bone metastases. If you have an elevated blood calcium level, it's a good idea to check the bones and make sure that nothing is going on there. As I said earlier, always rule out the cancer as a possible source rather than saying, oh, it's just arthritis, it's just fatty liver, it's just this, it's just that. Make sure that you know what you're dealing with. Most patients, if they don't have metastases, will still have lots of imaging going on. For example, every year for the first 2 or 3 years, even if it's a stage 1 cancer. And often they'll get their first scan 3 to 6 months after the surgery to make sure that everything is looking good. People who get stage 4 cancer, which is metastatic, or get recurrent cancer, will generally be scanned every 3 months, sometimes every 2 months, sometimes every 4 months, but much more frequently to keep an eye on what's going on. And we're fortunate today that metastases are not necessarily a death sentence. People do well for years and years and years. Some people get a complete remission, which doesn't mean cure. It means the cancer is visibly gone at that time. And that can last for years and years. And that's what we all hope for, of course. But scanning is great. You can do CT scans for chest, abdomen, and pelvis. You can do MRI for abdomen and pelvis. MRI is magnetic resonance imaging. Often that's done without contrast. That's a very good scan. Unfortunately, it can't be done for the lungs right now because the lungs move because you breathe. And the CT scan can cope with that. The MRI cannot. One problem that a lot of patients have is they develop cysts on their kidneys. This is a normal process that can happen to anyone. It's not limited to cancer. If you have a cyst, you might get an ultrasound to look at the cyst. And cysts are easy to recognize. They aren't worrisome unless they are complex cysts. And there is a scale called the Bosniak scale that can rate your cyst on how likely it is to be cancerous. So if you have a cyst, don't be worried, but do get the Bosniak rating and then find out what you need to know about whether that cyst presents a risk to you of cancer or not. Brain scans and bone scans are usually done only when you have symptoms of a brain problem, a neurological problem, or you have a problem with your bones. And if those are done, they can tell you, any kind of scan can tell you something is there, something is abnormal, but they can't really tell you what it is. So you need further care to find out what it is that's being seen on the scan. If you have a brain metastasis, you're likely to see a neurologist, but the oncologist is probably going to be the one who prescribes the treatment other than surgery. An orthopedic surgeon may be necessary to deal with bone metastases, or you might get radiation to the bone metastases, or you might have an interventional radiologist do an ablation, a radiofrequency ablation or cryoablation of bone metastasis, or also the interventional radiologist can do bone cement. That's called orthoplasty, or if it's in the backbone, vertebroplasty. There's also kyphoplasty. There's a procedure where a balloon is inserted into your back and inflated slightly to push the vertebrae apart, and then the bone cement is injected to hold them there. And that's a good method of repair. And these are all very non-invasive procedures that won't keep you in the hospital for very long. In fact, a lot of people walk out the same day. It's a day surgery. It's called less invasive than open surgery. At other times, you might need other specialties. For example, if you're on treatment and you're feeling really, really no energy, washed out, tired, just want to go to bed all the time, you might have a thyroid problem. And if you have a thyroid problem, you see an endocrinologist and they get your hormones back into adjustment and you will feel 100% better, hopefully. Another important member of your team that a lot of people often overlook is the pharmacist. The pharmacist can help you prevent drug interactions, can tell you whether what you're taking altogether is safe for you, can provide label warnings that people sometimes overlook, because when you're in the thick of things and you're in the doctor's office and the doctor says, watch out for this and this, you say, yeah, because you're not really paying attention to that. You're thinking, oh, no. And you're afraid and under stress, and you need time to absorb that information. The pharmacist can go over that with you. And another thing the pharmacist can help with is if you have financial concerns about paying for your prescription drugs, the pharmacist often knows how to get those drugs paid for other than your insurance, to help you with the copays and so on. So another thing that you might need, surgeons other than your urologist, if you develop a problem in another area of your body, and the cardiologist if you develop a heart problem of any kind, and any other kind of specialist. You might need any kind of specialist, but we don't say you're going to need all of them on your team at any one time. You need those doctors as a need arises. So you need to stay in touch with your doctors that you already have and ask, do I need another specialist? Does this problem mean that I should go see a doctor for my sinuses, a doctor for my intestines, a doctor for my digestive tract? And your doctors should be able to advise you whether you need a gastroenterologist or whether you need an ENT doctor. One weird thing about kidney cancer is it can go anywhere, anytime. People who have been absolutely free of disease can develop metastases 18 or 20 years later. This is not to scare you, but to say, stay alert, be aware of your body and what it's telling you, get problems checked out, rule out the cancer first, make sure that your doctor knows you want to rule out the cancer as a cause of any long-lasting problem before you treat it as a quote normal problem, like allergies or infections. And if you do all those things, you still might be worried. Who wouldn't be? So that's one reason why we have SmartPatients. SmartPatients.com is a free, safe, private forum where you can come and ask your questions. Should I be worried? How worried should I be? Where should I go? Where is an expert? You can find people who have had similar experiences who will tell you, this is what I did. We don't give medical advice. We do give personal experience and emotional support. And we help people from every stage, from diagnosis where they're just terrified, understandably, to people who've been dealing with this for many, many years. We have patients who've been there 16 and 20 years, who some of them have fairly early stage cancer that hasn't recurred and they've stayed on to help other people. Some of them are stage 4 people who are now NED, no evidence of disease. Some of them are in the throes of fighting stage 4 cancer or recurrent cancer. So whatever your questions are, you can come to SmartPatients to get them answered. But you do need to provide us in your posts with basic details about what you're dealing with. Otherwise, we can only give you very general answers. And the strength of talking to other patients is to get very, very personal answers for you. Like, are you close to this place or that place? Here's the place with the greatest expertise for that particular problem. And we have lots of people who are ready and willing to help you get through this. And with luck, with grace, with blessings, with information, with knowledge, with studying, you're going to do fine. So that basically wraps up what I have to say. Let's go to the questions and answers.
All right. Deb had a comment during the presentation, and if anyone has any questions, you can type them into the chat box, or you can temporarily unmute your microphone to ask your question. But Deb's comment was that outside of the United States, there is an approved treatment sequence or algorithm based on the clinical trials. That can be a good thing. It could be a bad thing. And Canada, UK, Australia, and parts of Europe is where it's available.
Yeah, and as Deb said, that can be a good thing. It can be a bad thing. If you happen to fit the pattern, it's great. If you happen not to fit the pattern and they really can only find that out by applying the pattern to you, then it's not so great. And one of the advantages that we have in the US is that if you get a first-line treatment and the first-line treatment doesn't really work for you, you can go on and get another first-line treatment. First line in the US just means this is probably the most effective. In some cases, it means you should try this absolutely first. But in kidney cancer, there's any number of treatments, probably 6 or 7, maybe more, that are listed as first-line treatments. And obviously, you can't try them all first. In the US, you can go on to another first-line treatment if the first-line treatment fails. Whereas in many other countries, they say, oh, you had your first-line treatment, now you have to go on to what's rated as second-line treatment. And unfortunately, a lot of the treatments are not rated as this could be given as first line or second line. It just says first line, second line, subsequent. In some of the patients that we have on our forum at SmartPatients have had 13 or so different treatments, and they're US patients. They've combined standard treatments, clinical trials, They go to experts. The expert tries everything and they find what is most effective. And some of those people have been fighting kidney cancer for 15 years. We also have a patient who was on the same drug, the same TKI, Sutent, for over 15 years and did pretty well on it. Whenever they tried him on anything else, it did worse for him than Sutent did. Sutent had a lot of side effects, it had a lot of problems, but his doctor was able to tweak the treatment, the timing, the dosage, combine it with other treatments, combine it with surgery, and get him through a long, long time of fairly reasonable life.
Wow.
So there's a lot to be said for following an algorithm and a lot to be said for deviating from it.
And Deb had a question for you. She says, with all of those ologists, who is the team captain? And is it for early stage 1, 2, 3, or 4? And how do you keep them all informed and coordinated?
That's a really good question. In general, either the PCP will be coordinating, or if you have a urologist and not an oncologist, the urologist might be the coordinator. If you have an oncologist, the oncologist might be the coordinator. Some oncologists would say they'd rather have the PCP coordinating. So a lot of it depends on your individual practitioners. A lot of times the patient has to do a lot of the coordinating. And an informed patient is better able to do coordinating than somebody who just says, "Doc, you take the wheel." So it's really good to have information to be able to ask informed questions, be able to say, wait, I think this is being overlooked. Because early stage patients do have different needs than late stage patients. And hopefully you have some time before you go to from early stage to late stage. So you have time to learn, time to benefit from gaining information, gaining insight, and becoming a skilled patient. Patient skills are something that you don't develop until you need them. You know, you're just sort of thrown into the medical system. And some people say, I want to learn all I can. And they find out if you learn all you can and you want to learn and you make it clear you want to learn, a lot of doctors will develop a team approach with you. If you just put it in the doctor's hands, you don't really know what you're going to get. It's sort of like if you went to a car dealer and you say, I want a car. And you haven't done any research and you haven't thought about your needs. And you don't know if you want a 4-wheel drive or a sports model or an economy car or an SUV. You put yourself in the hands of the salesman, you're going to get what the salesman wants you to have, not what's best for your needs. Doctors aren't really selling you things, but they do tend to focus on their specialty. So somebody says, if you go to a surgeon is going to want to do surgery. Well, that's true. If you need something like interventional radiology, where you want an ablation, or you want something that's less invasive than standard surgery, you really can't ask your surgeon about it. Your surgeon is going to say, let's do surgery. You need to advocate for yourself. And you need to find out, is this an option for me? Because doctors are like car salesmen in a certain way. They want to sell you their brand. The oncologist wants to do oncology. The surgeon wants to do surgery. You are
human nature. People stick with what they know.
Exactly. And they may not even know that these other things are out there. The same with clinical trials. Clinical trials are one of the best treatment options if you know what you're getting into. You need to shop for a clinical trial. You need to look at what you want. You need to look at your particular situation. And you need to know that there are clinical trials all across the country. And if you're willing to travel, you might be able to find a really great clinical trial Whereas if you ask your local doctor, are there any clinical trials for me? And he might think you mean in this area. Well, no, we don't have any clinical trials right now. That doesn't mean they aren't out there, but you may have to go take the initiative and go look.
Yeah, and clinicaltrials.gov, I believe, is still one of the best places for people to look, even though it's a little cumbersome going through all of that data, because there's a lot of information there. But correct me if I'm wrong, but I believe that the community on SmartPatients, there's a lot of people there that are involved with clinical trials that can share things about their experiences with that as well. Is that correct?
Right, and they can help you find if there are interim results on a trial. If a trial is now in phase 3, they may have reported on phase 2 and what the results were of phase 2 at a professional meeting. And the average patient doesn't know that. But the people at SmartPatients will say, well, let's go look, let's find the results of the earlier phase trials and see if that's helpful to you. Shopping for a trial is another skill that really takes some development.
If anyone is interested, we have had other kidney cancer conversations and brought in people with different perspectives, some patients, some doctors that run clinical trials, and had conversations with them. You can find those conversations on our website and our YouTube channel. Susan Kinney had a question for you. She asks, she says, my primary physician is the captain of my team. 29 years after my radical nephrectomy, she was suspicious of a clavicle lymph node and initiated a workup. Adrenal tumor and sacral tumor was identified and addressed. 4 years, and I am NEVD, and my primary is still on the ball. Thank goodness. That's fantastic, Susan.
That is.
Fantastic. Gail says, could you go over again what tests might be done for follow-up after kidney cancer surgery, such as chest, etc.?
Okay, sure. The gold standard, what most people get, what most people want, is CT scan of the chest, abdomen, and pelvis. And what some doctors want to order is X-ray of the chest, CT of the abdomen and pelvis. Don't settle for that. We have a lot of patients that have had small spots in their lungs that were not picked up on an X-ray or not noticed on an X-ray, that when they got a CT of the chest, there it was. And so CT of the chest, abdomen, and pelvis, and ideally with contrast if you can tolerate the contrast. That's the basic to remember. Then beyond that, it's as needed.
Any other questions? If anyone missed any part of this conversation, it will be on our website next week, and so you can follow us on Facebook, or you can check in on the website next week, and we'll have the video up then. And if we do happen to get any questions from the comments section of the videos, or if anyone happens to email us later, Robin, would it be okay if we contact you to get those answers?
Absolutely. Absolutely. I look forward to hearing from you. And of course, we're always available at smartpatients.com for any kind of question, general or specific.
Gail says, thank you so much for all this information. Deb favorited your comment about doctors being like car salespeople. They call it a specialty bias. That's funny. Well, Robin, as always, it was very informative. I was so glad to see you. Thank you for being such a good friend to the foundation and for lending us your insight.
You're very welcome. Glad to do it anytime.
All right,
care,
everybody.
Everyone. Stay safe.
That's right. That's it for today. I'll see you all next week, or not next week, next month, for our next conversation with Dr. Margarita Babonis. She's talking about coping with cancer and caregiver stress. So lots of good topics coming up. If you have any suggestions, please feel free to email us or comment on our pages on social media. We check those, and we'd love to have your feedback. So thank you, everybody, and have a great day. Bye, Robin.
Bye-bye.